to this webinar from Nova Biomedical. My name is Naveen Banga. I'm Director of Medical and Scientific Affairs at Nova Biomedical. Today I will be talking about the importance of magnesium, and I will highlight how comparisons of different types of lab tests are made to tell us about a patient. So the title of the presentation today is Point of Care Testing for Ionized Magnesium versus Laboratory Testing for Magnesium. Correlation versus concordance. I wanted to start with some case studies that highlight the importance of magnesium. And this is the first case study we'll talk about today, about a patient presenting to the emergency room, a 40-year-old female presenting with nausea, fatigue, diarrhea. So very vague symptoms that could be caused by a number of underlying reasons. The patient was taking 20 to 40 milligrams of omeprazole, proton pump inhibitor, and 20 milligrams of atorvastatin. And up until the days leading to the hospital visit, she was unable to eat or drink. As the hospital staff did some tests, they noticed that the ECG sinus had tachycardia, 125 beats per minute, and diffuse ST changes. Her hemoglobin was elevated, leukocyte count or white blood cell count was high, thrombocytes were high, and creatinine was elevated, which indicates a low arterial filtration rate shown there, 13 mils per minute, which is much less than the 60 mils per minute. She had impaired kidney function here, shown by the creatinine. So she was admitted to internal medicine, had acute renal failure, and was dehydrated. And critically ill at 5 hours, hospital stay, convulsions, cyanosis, and had consciousness, so becoming quite severe. The hospital staff quickly did immediate resuscitation, and ECG showed Torsades de Pointes. So this is a situation where often this responds well to. So a bolus magnesium injection was given to regulate the rhythm. And the diagnosis was severe hypomagnesemia. The magnesium you see is less than 0.27 millimoles per liter, well below the reference range there. And the patient was discharged with oral magnesium supplements, 14 days stay. However, 3 months later, the same patient returned to the hospital with hypomagnesemia again, still at 0.28 millimoles per liter, even though she'd been given those supplements. And they determined that the hypomagnesemia was due to the proton pump inhibitor omeprazole. Upon questioning, the proton pump inhibitors, omeprazole was being used for 13 years, and so quite an extensive time. But normal magnesium levels were seen in this patient 7 years earlier. So something happened in the last 6 years to precipitate this hypomagnesemia. So at this point, after the second visit to the room, proton pump inhibitors were stopped. The patient was monitored as an outpatient, stable 5 months post visit. So what I wanted to highlight from this situation, this case report that was published in 2016, first of all, is that magnesium imbalance or deficiency presents often with very vague and common symptoms like nausea, fatigue, and diarrhea, which again can be caused by many underlying causes. And so it's a bit of a challenge to diagnose. There are many things to rule out here. The crisis at the lost consciousness at 5 hours, that could have been avoided had they had their fast, quick magnesium result done in the emergency room. And the return to hospital could have been avoided if there was awareness that magnesium is impacted by a proton. That is, proton pump inhibitors cause magnesium. And this was well known from a 2011 safety communication from the FDA that long-term use of proton pump inhibitors is associated with low magnesium levels. And some of the common brand names, things like Prilosec, Zantac, Nexium, Prevacid, and omeprazole. And the study was from 2016, so 5 years after that FDA communication. So the next case study I want to talk about, the first case study was about magnesium deficiency caused by proton pump inhibitors, so something very commonly taken, over-the-counter medication taken by many people. And in this case, another case of magnesium imbalance presenting to the emergency room, but this time elevated levels of magnesium. So this is a 53-year-old female admitted for acute exacerbation of chronic obstructive pulmonary disease, or COPD, and a history of chronic constipation that she was treated regularly with laxatives. Those laxatives are often magnesium-containing, things like milk of magnesia. And her magnesium was 2.0 milligrams per deciliter, but rose to 10.8 milligrams per deciliter, so very high, despite dehydration and being diuresed, and she had normal kidney function. So it wasn't that her kidneys were unable to excrete it. There was some other cause here. And I'll show you later the role of the kidneys in maintaining magnesium balance. So renal replacement therapy, or CRT, was initiated to try to reduce the magnesium, and the patient continued to deteriorate, progressed into shock, and leading to renal failure. And the authors of this study of 2018 noted that severe hypermagnesemia frequently results in death, even when there's normal renal function and there's renal replacement therapy being used. And the surprising finding here is that this constipation, which is the reason for taking the laxative, when the laxative that's magnesium containing is taken, it tends to be retained in the gut, and that because of the constipation, that serves as a reservoir for continuous magnesium absorption, and that contributes to mortality, actually. So having the constipation is a potential hazardous situation with magnesium laxatives. And these are some of the different brands here of milk of magnesia with their different companies. And these laxatives have quite a high concentration, or quite a high amount of magnesium, on the order of 1,200 milligrams per dose. And when we think about magnesium supplementation of a patient who's, or by oral supplementation, for example, of someone who's deficient, we're talking about things like 200, 400 milligrams per day, for example. This is 1,200 milligrams per dose here, so it's quite high. But again, with constipation, that leads to a reservoir in the gut that can continually absorb into a patient. So the third case I want to present here is, again, another magnesium imbalance of a study where a group in Japan was looking at looking back at their ER visits and asking how often is magnesium deficiency observed. So this is a case report series where they had 4 patients that they had identified over a 3-month period. So you can see here an 88-year-old female presented again with appetite loss and weakness for 3 days, severe dementia. She had severe dementia. She was bedridden, and a history of stage 4 chronic kidney disease. So creatinine was quite elevated at 2.7. Meaning the GFR was quite low at 13. And she had been taking magnesium oxide, 660 milligrams per day, for the past 2 years. So when she arrived at the hospital, she was drowsy, her blood pressure was 130 over 80, and her pulse was regular. She had a pale complexion, dryness, cutaneous dryness, and lethargy again. And a classic sign of magnesium deficiency or magnesium imbalance is these tendon reflexes. So she had hypoactive Achilles tendon reflexes. She had severe anemia. Her hemoglobin was 7.9, hematocrit 24.6, creatinine, acute kidney injury as seen by her serum creatinine at 5.2, quite elevated, both hyperpotassium and hypermagnesium levels. And her blood gas showed a metabolic acidosis with a pH of 7.29. Her ECG showed the sinus rhythm and a mild QT prolongation for 467 milliseconds. Again, this is similar to Torsades, which is also, you see this prolongation in the sinus rhythm. So hemodialysis was considered for this patient to help improve the magnesium levels, but the family did not improve. Instead, she was treated with 20 ml infusion of calcium gluconate to prevent the arrhythmias and IV isotonic fluids to get her hydrated again. After 11 days, she had loop diuretics to increase renal excretion of potassium and magnesium, or they're both high. And over this time, serum magnesium and potassium decreased, and the creatinine improved to 4 mg per deciliter. So on the 14th day, she was discharged on day 15. So things started to be improving. The electrolytes were coming down, and her renal function was improving. And again, this shows that presentations of magnesium imbalances show up in the emergency room with very vague and common symptoms, and some of them can be quite severe consequences. The drugs and supplements that are being that are causing this are quite common. They're over the counter. Often the level of magnesium or the extent of magnesium is not being considered, certainly by the consumer, the patient, but is it being considered by the physicians that are coming, the ER physicians and staff when the patient comes in? And I direct you to the right side here, showing our metabolic panels, a basic metabolic panel on the left here, and a comprehensive metabolic panel on the right, and the tests that are included in each. You can see the calcium, which is a divalent cation, is included in both panels. But no, and electrolytes, things like potassium and sodium are seen here, glucose, and kidney function here for creatinine. You can see the one thing that's missing for sure is magnesium, and it's often called the forgotten electrolyte. And that's this is evidenced here. So what this means is that when patients present with these vague symptoms and a physician calls for either a basic or a comprehensive metabolic panel, they're not getting a magnesium test result. And that might be problematic, because what this means is that the physician actually has to think additionally about, is magnesium an issue here? And like the link between proton pump inhibitors and magnesium might not always be jump out at someone who's seeing a patient like this with many things to rule out. So there could be an argument to be made here that these metabolic panels could be improved by adding a magnesium test, for example. So I gave you some case reports on the importance of magnesium, how it presents to the emergency room. Now I want to come back to some of the basic biology of how magnesium is maintained, how magnesium balance is maintained. So homeostasis of magnesium looks something like this, in the sense that we have dietary intake of magnesium. It gets absorbed in the intestines into the blood. In the blood, then it gets filtered through the kidneys. The kidneys do a very good job of reabsorbing most of the magnesium to maintain our levels. So 2,400 milligrams is filtered, 2,300 is reabsorbed. And then magnesium largely sits in the bone for strength and density, in the muscle for contraction, and in other soft tissues. You can see the levels here are quite high, 12,900 in the bone, 6,600 milligrams in the muscles, and 4,900 milligrams in the soft tissues. So magnesium is important in many different processes. One I mentioned earlier was cardiac rhythms, or magnesium deficiency can lead to arrhythmias. Things like neurotransmission, inflammatory pathways, metabolism, and it's a cofactor for more than 600 enzymes. So it's very challenging to understand just exactly, specifically what magnesium is doing in a particular patient for causing specific symptoms. So what could cause hypomagnesemia? One is certainly dietary intake. Green leafy vegetables are high in magnesium, and that's because magnesium is the center of the chlorophyll molecule. It's found in plants, versus processed meals. So if we're eating more processed meals, we're not getting as much magnesium. So that could be a cause of low magnesium. If there's inefficient absorption in the gut, and that can be things like bowel diseases like Crohn's and ulcerative colitis, that can cause improper or not insufficient absorption. But most relevant, and then finally excretion. can cause imbalances in magnesium, since the kidney is doing a good job of reabsorbing in situations where syndromes like Barter's or Gittleman's or renal tubular acidosis, you may not get sufficient reabsorption of magnesium, and that again can lead to hypomagnesemia. The most relevant and most common effects of that we will see of magnesium imbalance, or causes of magnesium imbalance, include secondary causes. Things like diabetes are associated with hypomagnesemia. The medications that are given, things like thiazide diuretics, proton pump inhibitors I mentioned, nephrotoxic drugs like aminoglycoside, antibiotics, cyclosporin and tacrolimus are both immunosuppressants that cause magnesium wasting, and cisplatin is a chemotherapeutic that's used to treat cancer patients, also causes magnesium wasting. So these are often seen in the hospital where magnesium is affected by some other medication or situation, but it's a secondary cause. And just to blow up and do a close-up of how magnesium is absorbed in the kidney. This is showing the loop of Henle here, and where magnesium is absorbed, 70% is reabsorbed in the thick ascending loop, and some more in the distal convoluted tubule. This reabsorption is some of which is passive diffusion, shown here, and in other situations, in addition to that, there's also the use of TRPM6 and TRPM7 type channels that in the distal convoluted tubule that allow magnesium, active reabsorption of magnesium. At the cellular level, I mentioned magnesium is important for cofactor for over 600 enzymes. And so you can see here in this diagram, magnesium in various places in the cell. Here's TRPM7 and the import of magnesium. It's involved in the mitochondria, it's involved in the nucleus and DNA replication and repair. But I want to highlight one situation here, which is this epidermal growth factor, or EGF, and the receptor on the cell, because this signal, epidermal growth factor binding to its receptor, leads to magnesium import by TRPM7 channel. And it's relevant because epidermal growth factor receptor signaling, this signaling is a growth factor for and a replication signal for cancer cells. Specifically, colon cancer cells have been shown to respond to this and grow rapidly. So there's a therapeutic to block epidermal growth factor receptor here, and that's things like cetuximab, was one of the first generation. And cetuximab is an antibody to EGF receptor, and what it does is it blocks the signaling, but it also then blocks magnesium uptake by the TRPM7 channel. And so patients that are on cetuximab have severe magnesium wasting, to the point that the magnesium wasting causes them to, or forces them to stop taking their cetuximab treatment or their anti-cancer treatment. So quite a dramatic effect of having magnesium wasting as a side effect of that drug, and its importance in various biologies. So what are the symptoms of dysmagnesemia? I talked about some of them, the very vague and common symptoms of lethargy and weakness, and you can see that here in some of the hypermagnesemia situations. In the case of hypomagnesemia, you can get arrhythmias, as I mentioned, confusion, things like seizures, muscle cramps, and delayed type, longer delayed type tendon reflexes, deep tendon reflexes. So how do we test for magnesium? It's distributed, as I mentioned, through the muscle and the bone and the soft tissue for the most part. This is most of the body. Magnesium is distributed, and only 1% is in our blood or in the vasculature. In the blood, you can see that magnesium exists in different forms. That is, most of it, 55 to 70%, is in the ionized form or free unbound. So that's magnesium with two positive charges. 20 to 30% of magnesium in the blood is bound to proteins such as albumin, and a small percentage is complex to citrate or bicarbonate, and those are called chelates. So that's how it's distributed in the blood. And what we're measuring in the blood is similar to calcium in the sense that it's a divalent cation. So it's well established that for calcium, the same populations exist. We have ionized calcium here shown in blue as a Ca++ in a healthy individual. Here's the chelates, those are called complex to bicarbonate or citrate. And here's protein bound to albumin. So this cylinder, blue, red, and yellow, all together represents our total calcium. In the case of hypoalbuminemia, so low albumin in a patient, you have less albumin here to bind the calcium, which means this red fraction drops down. Your total levels of calcium are actually decreased because of this. But that doesn't mean that you're really low in calcium. Your ionized levels are the same, and that's well understood. So for calcium, often a corrected calcium can be measured, or an ionized calcium, and that gives you a true, accurate reflection of the biologically active calcium. And in a similar way, then magnesium is also a divalent cation with two positive charges shown here on the right. And if we draw the same type of cylinder diagram, you've got the ionized fraction, magnesium with two positive charges. You have the chelates here, and then protein bound. And again, it's the blood levels are about 1% of the total in the body. So what are we measuring then? For calcium, often ionized calcium can be measured, and in the case of magnesium, it's often only total magnesium, even though there is opportunity to measure ionized magnesium. So what does measuring magnesium look like? This is just showing the adult levels of total magnesium in milligrams per deciliter. In blue here is the normal range, 1.46 to 2.6. And ionized magnesium is really just left shifted because it's a fraction of the total. You can't always predict how much ionized, how much the fraction is of ionized to total in any given person, in any given patient, because it varies. But you can see that in general, it's left shifted. It's 1.09 to 1.45 is the normal range for adult ionized magnesium. And again, going back to this similar diagram of the cylinder, you can see again the ionized fraction here is 1.09 to 1.45. That's the normal range. And then the total, which is the red, yellow, and blue, all summed together as one number, is 1.46 to 2.68. So before I get into comparing ionized magnesium to total magnesium and how those comparisons have been shown, published in the literature, I want to step back for a moment and look at what is correlation and what does it mean. So correlation is really how two parameters, in this case ionized and total magnesium, rise or fall together. And you can see here, if there's two parameters, pull out on the X and the Y, and there's a scatter plot here looking like this, then really there's no correlation. As you move up on the X, really there's no directional movement on the Y. You can see a perfect correlation is a value of 1, or R value of 1 usually. And you can see that as you increase in the X, you get a similar increase in the Y, and it's a perfectly linear relationship looking very nice. So in this case, both parameters rise together. And now, what value of what R value, 0.75 or 0.5, you can see the scatter values. You can see a general trend to increase together. And when you think about what represents a good correlation in a lab, or if there are two parameters where there's no known relationship, completely random molecules that we don't think of as related to one another, or in the same functions, or in the same biology, then maybe a correlation of 0.5 might be very good. You might think, wow, that's quite surprising that these two molecules show a correlation of 0.5. Maybe they are related and we didn't know it, and that's would show good correlation. However, in the case of ionized magnesium and total magnesium, we're really talking about two forms of the same molecule. They're both magnesium. One is just bound and the other is free. Or one is bound and free and the other is free alone. And in this case, it would be expected that they would rise together to some extent. So is a correlation of 0.5 very good? Maybe not. Maybe then you'd say, well, why are those two forms of the same molecule actually quite different? So let's look at some data and some comparisons of ionized magnesium to total magnesium. In this situation, this is a study from 2017 looking at the medical ICU unit in a Boston hospital. And what you can see is in these patients, you can see magnesium, total magnesium measured is on the x-axis, ionized on the y-axis, and you can see each of these dots represents a patient who is measured by total and by ionized magnesium. You can see the normals here in green. Normal range for total magnesium here is in the middle section, and similarly for the ionized magnesium here, it's in the middle section. So the normals that were the patients that were identified as normal by both tests are shown here in the middle green square. Both tests showing reading high for the patient, any given patient are shown here in the upper right, and both tests reading low down here in the bottom. So when we talk about low or high and from the normal range, we're actually talking about clinical categorization. And that allows us to identify whether a patient is low in the normal range or high. So that's called clinical concordance or agreement. And if they disagree, then it's clinical discordance or disagreement. So it's not just about correlation, but it's also about which clinical category these patient falls in as to how they're treated. So in this case, what you can see is that the agreement here in the low by both tests, low total magnesium, low ionized magnesium here 6, normal for both was 277, and high for 50 was 51. So 334 of these total 470 patient samples were actually agreed. So there was a 71% concordance overall and 29% discordance. And that's in clinical agreement terms. So when you look at this, and this is surgical ICU, same patient population, 30% were not concordant. The total mag tests were not concordant with ionized magnesium. And when we look more carefully, what that means is actually, first of all, 30% were not concordant means 30% of all these dots are falling outside of the green. So this is in the orange here, 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 here. So 70% are actually within the green shaded regions where there's true low, both reading low, both reading normal, and both reading high. When we look specifically at the low total magnesium test, those patients that were called low by the total magnesium test, you can see that if we consider all of these as our 100%, these on the left column, then there's far more patients here in the red that are normal by ionized magnesium and low by total magnesium. And that's about 80% compared to 20% that are both in the low. So there's really 80% discordance when you're looking at the low total magnesium patients. And that's relevant because those are the patients for which you're going to need to supplement. And in this situation, the authors noticed that this 80% discordance in the low total magnesium, where you had falsely called low patients, so falsely called low by the total magnesium test, but the ionized magnesium test was reading normal, shown here, ionized magnesium, and this is the normal range. That led to unnecessary medication administration and repeat testing and consults that could have saved the hospital $168,000 a year for their 2 ICU units. So the next study I want to look at is one quite recently from 2023, presented at the European Renal Association conference. It's a large study with 1,741 chronic kidney disease patients, and the authors here argue that the total magnesium and ionized magnesium were strongly correlated. R value of 0.88, which is, and you can see they both rise together. It is a pretty good correlation that you're looking at. And, you know, so when we look at this by clinical category, though, you can see again, total magnesium here's on the x-axis. Here's the normal reference range by these 2 lines. And for ionized magnesium, they separate into tertiles, and the middle tertile is approximately the reference range. When you look at these by clinical category, then, in the normal magnesium levels, you can see these purple dots. And that's quite a large fraction of all of these normals are actually being called normal by total magnesium tests, but the ionized magnesium calls them high, so they're up here in tertile 3. And again, when you look lower at in the normal total magnesium patients, you can see that their ionized magnesium here are low, and those are these yellow dots. So even though they're being called normal by total magnesium, by ionized magnesium, they're hypo. So you've got really 3 different categories that are spanned by the normal magnesium tests. And that represents a pretty large fraction of these dots. If you consider all these dots as 100%, this is probably more than 50% when you consider the purple together with the yellows compared to the green. So we call that probably at least 50% discordance, and the authors didn't do this type of analysis actually. But when you notice, what's surprising, or maybe not, is that ionized magnesium in tertile 2 are basically all called normal by the total magnesium test. There's only 2 dots out here, 2 patients out here, and 1 here. So most of the ionized magnesium tests are also being called normal by the total magnesium test. And so I think that's a reflection of the fact that ionized magnesium is the biologically active form, and that's the one that's most regulated by our bodies. Whereas total magnesium can vary with the amount of ionized magnesium in those individuals. So looking at a few other studies then, in thinking about correlation and clinical category. So in this case, you've got chronic renal disease patient and transplant recipients where the R value is 0.73, so not a bad correlation. You can see they both rise together, total magnesium on the X, ionized magnesium on the Y. And you can see again the reference ranges here by these dotted lines, the middle on the X and on the Y, ionized magnesium here. So both in the patient group and in the control subjects, the R value was 0.73 and 0.75 respectively, which is not bad. But then when you look specifically at the low total magnesium, again, left side of the graph, you can see that if you consider all these dots as the 100%, only one fell in the correct place for both tests, the ionized magnesium being low and total magnesium being low here. The others where total magnesium is being called low, but ionized magnesium being called normal, you can see shown here, that's probably more than 90% of those patients in the low total magnesium category. Overall, though, when you look at all of these dots, and the number that are actually here in the false hypomagnesemia, meaning called hypomagnesemia by total, but normal by ionized magnesium, that's 15 to 20%. So not that much, but only when you look at the low fraction, you notice that there's 90% actually discordance. So I've shown you a lot of data comparing ionized and total magnesium and looking at one is low and the other is normal. And what does all this mean in terms of the homeostasis and the biology? And when you look at this diagram of homeostasis of magnesium, and I remember I mentioned muscle and bone being very high in the amounts of magnesium, this just has to be bigger. We need to represent it as a larger fraction. And it's probably in equilibrium here with the blood. And here's the blood magnesium shown in that similar cylinder diagram that I mentioned before. And when you consider the total magnesium test and the ionized magnesium test in this kind of diagrammatic way, in a healthy individual, they're both normal. Ionized magnesium is here, normal magnesium is total level is here. You've got the sum of the protein bound and the chelates and the ionized. But what happens when you're starting to undergo depletion? And I think what happens is the protein-bound form of magnesium serves as a reservoir to replenish the ionized fraction as it starts to deplete. And that helps maintain the ionized fraction at a constant level. So what happens in some a subtle level of depletion, then your total magnesium will drop because your magnesium is being depleted from the protein-bound pool. You can see the red fraction drops. And the total level drops, but the ionized fraction is staying the same. So therefore, your total test of magnesium is low, your ionized fraction is staying normal. That's the one that's being more tightly regulated. And as you go through further depletion then, The albumin-bound magnesium is still trying to maintain the levels of ionized magnesium, but it can't keep up. And so if it can't keep up, if there's not enough there, then the ionized levels will also drop. So you see the blue bar has dropped, ionized magnesium has dropped lower to low, and the red or total amount has dropped low as well. So both tests, both the total magnesium test reads low and the ionized magnesium test would read low. So really ionized magnesium is a true reflection of that low status in this kind of model. And it's really in this state of low ionized magnesium and low total magnesium when you probably are depleting sufficiently from muscle and bone, for example, that you're seeing symptoms like muscle cramping, like cardiac arrhythmias, and so on. So it's probably there that you're seeing these types of clinical symptoms show up as well. So I wanted to summarize then that what I've gone through is really that imbalances in magnesium can have quite severe consequences that present with common and vague symptoms, often to the emergency room. Some of these imbalances can be caused by proton pump inhibitors, which cause depletion. Things like laxatives or supplements can cause hypermagnesemia, and especially in the presence of constipation or renal disease. So remember that constipation can lead to a reservoir of magnesium sitting in the gut that can be continually reabsorbed. And ionized magnesium is the biologically active form. They both show a correlation. Remember the R value is around 0.7, even in the CKD study. The large CKD study was R value of 0.88. So correlation can be quite good. And of course, that is expected to some extent because they are both forms of the same molecule. But when you consider if you had to replace a test with another test in the lab, the FDA often requires correlations of 0.9, R value of 0.95 or greater. So in that context, an R value of 0.7, 0.75, 0.8 is not really that great. It's not sufficient to be a substantially equivalent test. So nonetheless, the correlation, as I've shown you by clinical concordance or agreement, is quite poor in almost every situation that we've seen here. So it's something to be cautious of and consider what actually type of magnesium one is measuring. And then supplementation based on ionized magnesium can reduce cardiac arrhythmias and can save costs in the ICU. That's combined with regarding a study that I haven't shown today, but the saving costs in the ICU I mentioned. And so lastly, I wanted to share that Nova Biomedical does make an analyzer that's point of care with for less than 2 drops of blood, and in 2 minutes you get a 22 panel of results, including blood gases, electrolytes, including ionized calcium and ionized magnesium, things like glucose, lactate, BUN, and creatinine for kidney function, as well as hemoglobin, hematocrit, and co-oximetry. So quite a large and important battery of tests. It includes also estimated plasma volume, which is a measure of fluid balance, so sometimes important in emergency rooms and critical care. That's useful for patient care. So with that, I will pause. We'll take questions and comments, and we'll just take a minute for people to type their questions into the chat. And while we're reading, I'll just mention that if your question was not answered live online here, then we'll certainly email. Somebody will get back to you, email you with a response. So please feel free to enter your questions into the chat. Okay, our first question is, do emergency rooms often have this type of testing available? And the answer is yes. Most emergency rooms have some sort of analyzer like this in their facility, so that results that are needed quickly don't need to go to the lab and they don't need that time delay. The Nova Biomedical Prime Plus is the only such analyzer that measures ionized magnesium, as well as all those electrolytes and metabolites that I mentioned. So yes, many emergency rooms have it, but often some don't have the capacity to do ionized magnesium. And I'll also say that I've recently come across some hospitals where they've added magnesium to the metabolic panels. So as I mentioned earlier, the basic and comprehensive metabolic panels don't have magnesium as part of their constituents of their testing, but some emergency rooms are using this as a common practice, as a routine practice, to just add magnesium to their testing. Okay, next question is about the correlation and concordance issue. What do you consider as a good correlation for two parameters? So this is a good question. I think, as I mentioned, if two parameters are unrelated, then they would, a lower correlation like R value 0.5, 0.6 might be impressive or interesting. When a molecule such as magnesium is in two different forms, ionized and total, then it may not be, it may be obvious that they're going to have some correlation. And as I mentioned, of substantially equivalent tests, as determined by the FDA, is something that requires an R value of greater than 0.95. So ionized magnesium and total magnesium really don't satisfy that strict or stringent criteria of being equivalent tests. They each are giving different information. The ionized magnesium test measuring the biologically active form. Okay, our next question is about cardiac arrhythmia. So the question is, magnesium is important in cardiac arrhythmias, and how big is this device? Can it be put into other parts of the hospital? Oh, great question. I think you're speaking about cardiovascular surgery, certainly a place where cardiac arrhythmias are seen, and magnesium needs to be supplemented quite rapidly at the time during surgery, for example. So the unit, the Prime Plus device, is about 30 centimeters across by 60 centimeters high, for example. And so small benchtop unit that can also be put on a cart. And it is often placed in cardiovascular ICU units or in cardiovascular surgery units to do exactly this type of testing and monitor patients for magnesium imbalances that may lead to cardiac arrhythmias. Quite commonly used, especially in pediatric cardiovascular surgery. So yeah, the Prime unit, the analyzer can be placed in many different parts of the hospital to give fast results for when something like ionized magnesium needs to be measured, as well as the other electrolytes, for example, blood gases and so on. Okay, looks like there are no further questions, so I'd like to thank you for attending this Nova Biomedical webinar and hope you have a great day.